Hi, I would like to welcome you all. I am in the fourth year resident in the third psychiatry clinic in Bakırköy Mental Disorders Hospital. I'll talk about pregnancy and antipsychotic use. There is an increase in the prescription on the antipsychotics. Psychotics. The third psychotrope drugs are the atypical antipsychotics, bipolar disorders. It is used in bipolars and other disorders. If we consider the unplanned pregnancy level is 40%, the clinicians treating the fertile pregnancy and for a pregnant woman, it's very highly likely that they could have a chance to treat a pregnant woman with antipsychotics. Schizophrenia in pregnancy has a relapse risk. It is 6.9, and after post-pregnancy it is 37%. However, it has a relapse 2 or 3-fold higher risk of relapse, and there are some risks from first trimester to third trimester, such as that infant, sudden infant death, and neonatal. There are many risks, in a large scale. In bipolar disorder, the recent studies show that the bipolar development and recurrence is increased, and the recurrence risk when the drug is quitted is 3 times higher. It is the most common risk, 15% in developed countries, and in underdeveloped countries, 20% prevalence of bipolar disorder. In the determination of the treatment method is instead of the opinion of drugs are harmful in pregnancy, it is about the drugs and their adverse effects should be taken into account, because in ethical terms, pregnancy research is not in golden standards, and there is a flow of data for malformation or the death rates. There isn't a series of data flow, but there are some risks for the mother and for the infant. So for each case, there should be a different treatment selected. Of course, in the risks of antipsychotic, for example, for a schizophrenia patient, for malnutrition, alcohol and cigarette comorbidities, smoking increases the comorbidities. Contraception should be recommended. In schizophrenia, bipolar morbidity and mortality risk increase, and sudden drug quitting is not recommended. And in the infants, the negligence and also abuse risks are increased. The factors that could affect the treatment, if related to the patient, the clinical evaluation is very important. The psychiatric history of the patient and the psychotic relapses, and also if there is a sexual abuse in this pregnancy, the family support, they are very important, and giving information and also records are very important. Gynecologists, pediatricians, and after we inform, they should be kept. The records should be kept, and it's important for sharing the medical responsibility. And also the mental training, it's very important for family to know the symptoms, and also the evaluating the capacity is very important for the pregnancy. The family history should be taken, and consultations should be made for pregnancy health because malnutrition and vitamin deficiency is a huge risk, and the treatment options should be selected, and ECT and TMS is important for somatic treatments, and also psychotherapy. If there is a miscarriage history, if there is an anxiety of miscarriage, it is important. And if in the follow-up for the pregnants who do not accept the treatment, therefore the follow-up is very important. There are complications because of the disorders, and pharmacotherapy is important. In pharmacotherapy, minimal dose monotherapy is recommended. Actually, we were told that rather than right or wrong treatment, what is useful for the patient should be taken into account. Physiologically, of course, there are some changes in the patient. Gastric discharge time increases, the relapse increases, albumin level decreases, and protein binding low drug happens. If we are to take a closer look, the enzyme P450 C9 activity is increased, and risperidone and albumin level decreases, and for CEP2 the activity decreases and serum levels increases. For CYP2A for ISO, that there are different results, but the activity increase is in the third. For quetiapine and neurostone, it is important. So therefore, there are some changes in fetus, like hepatic metabolism, and also the transit blood-brain barrier. The concentration could be higher in maternal levels, so the maternal serum should be enough. However, the fetal circulation should be very low in drug selection. In the transplantal transition, there could be fetal. It is important barrier for fetal exposure. If we are talking about immature renal system, the placenta actually plays a very important role. The placenta concentration is in transplacental transition is important. In the studies, olanzapine 72, haloperidol is 65%, quetiapine 23% has a placental transition. And P-glycoprotein substrate affinity is important. In high affinity, risperidone and quetiapine is low, and clozapine and olanzapine is higher. When we consider the clozapine has a B and the other psychotics has in C category. If we take a closer look at the antipsychotics, the first generation ones, in the infants exposed to this, the newborns exposed to this, 1,030 infants were followed up, and it was seen that there wasn't a significant difference. Regarding haloperidol, there isn't a heterogenic risk between 1977 and 1997. There are some research increasing heterogeneity. However, there isn't a major anomaly risk, and there is a low labor birth, and compared to control risk, there wasn't major anomalies. In trimester, extremely abnormalities were observed. However, it was not supported with the larger case series. Chlorpromazine. Again, haloperidol and its use in trimester. There is withdrawal syndromes, and after birth, there were some perinatal syndrome symptoms were observed. For chlorpromazine in trimester exposure is heterogenic. There are some research supporting this. Actually, gynecologists they actually used administered this in the past. So there's why the information flow is there, and there is a withdrawal, and then the extraparental symptoms were observed. So it is quite concerning regarding the high dosage and prematurity increase. There was an increase in the infants. There was a cyanosis of infant newborn fever were observed in 2 studies. In the mother, the cognitive and emotional development is normal. In 284 patients, there wasn't any increase in physical malnutrition. And other atypical antipsychotics, fluoxetine, has no long-term effect. There was cardiovascular defect in one out of 13 women, and extrarenal system findings were there. And then there were in 2 women, and triosidin in 2 infants, there was a major malformation, and flumexol, we have 3 cases only. Regarding the birth and infants, there wasn't an abnormality. For tilipepiracin, there was 1.7% increase in the lip-related symptoms. For trypamazine, in 480 exposed babies, there was 1.1 abnormality. However, this in normal population, it is 1 to 3% anyway. And the long term, for the birth defect, there wasn't an increased risk for the 2nd generation antipsychotics. Heterogeneity risk is low, however, metabolic risks are increased: obesity, hypertension, gestational diabetes, and some complications, maternal and fetal complications using the vacuum, and again, the breast cancer risk. For clozapine, 15 out of 200 babies, there were fetal malformation and hypoxic encephalopathy was observed. And in addition to clozapine, there was also the use of other medications. Regarding clozapine, gastroesophageal reflux, fetal cardiac arrhythmias, fetal agranulocytosis, and there is the risk of episodes. Therefore, clozapine babies for 6 months, their white cells should be followed up. There is 102 retrospective cases, 5 congenital malformation, 5 perinatal problems, obesity, gestational diabetes, and their effects on the infant. And also C-section, and also forceps use and vacuum use, the effects on the newborns is important. The producer company 22 malformations out of 523 cases, and they reported as safe. Olanzapine in the rats, the maximum with this in a study with the 7% more than the normal level. There were the heterogeneity. However, there are other drugs used. So there was ICU level is high, but it's not statistically significant. There was major malformation, but the metabolic problems, obesity risk, fetal complications, that birth and labor, and regarding this, there isn't any finding. In a study where 60 pregnancies were studied, 1 major malformation, and in another study, 79 pregnancies were examined, there were reflux and also there were some digestive system problem. And in another study where 610 pregnancies were examined, there was spontaneous miscarriage and 8% perinatal complications were there. For cesarean C-section, risk is higher in olanzapine use. For risperidone, with the extended release, there is one study. There wasn't any pathology in a case followed up for 8 months. In another group, there wasn't malformation examined until 12 months. There were withdrawal syndromes and for pulmonary malformation, and there were 15 malformation in 713 pregnancies. Quetiapine in 277 cases, there was a major malformation in the 8 cases, and in 290 cases, in 14 there were congenital anomalies, and in 39 retrospective cases there wasn't malformation, and in 21 cases 2 cases were reported. Regarding ariprazole, we don't have much data. There were animal studies. There could be cardiac problem, pragmatic hernia, and also decrease in fetal weight. And in the humans, 3 cases for 6 months follow-up. There wasn't any malformation. For ciprocin, there was skeletal a delay in skeletal development and increased mortality. One malformation, however, and for there are some studies comparing first and second generation, 284 pregnancies in a controlled study, and in the group using an atypical antipsychotic, the major malformation risk increase, and spontaneous abortus, there wasn't any difference. For the there was a premature labor. It's a classic. So this shows that atypical antipsychotics are safer. However, a systematic review shows that in metal percentage, major malformation risk there wasn't a significant difference in use of first and second generation antipsychotics. In Swedish work for the gestational pregnancy, there was a 1.7% risk for atypical and typical. The pregnancy follow-up actually starts with before the pregnancy. Weight, size, and folate, and multivitamin support. ECG is important, and the 12-week ultrasound, and the blood pressure and amniocentesis, and 16th week another test, and in the 20-week high definition ultrasonography, weight, blood pressure, thyroid, vitamins, and liver tests, and for 24 to 28 to 34 fetal development evaluation, and again then the thyroid, iron, and the complete blood scans are important, and 40th week, and if necessary, all the tests should be repeated, and continuous glucose tolerance should be continued. Withdrawal, sedation, and toxicity tests should be made. I'm wrapping up as the updated approaches. It's important to give information regarding contraception to women in the reproductive health age. And also, if it is planned pregnancy is recommended, monotherapy, minimal and effective dosage, and 5 mg folate and multivitamin supplement should be started 3 months before pregnancy. There's the medication treatments should be there, and good communication should be established, and the patient should know the early symptoms, and what to be done is important. As I pointed out, there should be the written consent is very important for sharing the responsibility, and the risks and the benefits of antipsychotic use should be discussed, and the multidisciplinary approach there, pediatrician, social worker, the gynecologist and psychiatrist should work before. And also regarding the unwanted effects, there should be information, and close follow-up should be there, and postnatal care in hospitalization should be extended. Thank you very much for your attention.